this morning I have been uh, tasked to give all of you a introduction and also a brief lecture regarding advanced care planning. So advanced care, what I'm going to do is in this lecture this morning, I will define what is advanced care planning, and which we usually call as ACP. And why do we need ACP? What are the components of ACP? We'll discuss regarding some disease trajectory, why we need to know, or why do we need to I would say, be aware of what disease trajectory a patient is in to help us, guide us with our ACP, and what is the component and process of doing a ACP. So I would start off by an introduction. Advanced care planning is not just about an old age. It can be initiated and started at any age. It is, what happens is when there is a medical crisis, which makes us too ill or unable to make our own decision, this advanced care planning would be a good guide for the physicians caring for you to be able to give the best care to what you may, as a sick person or your patient feels they would want to have. So even though we are not sick, or even if the patient is not suffering from a terminal illness at this point of time, planning for the healthcare in future is an important step to enable us to be aware, to be able to get what the type of medical care we want. And this advanced care plan would be the right tool for us to be able to let the physicians be aware of what we want when we are unable to tell or speak for ourselves when we need our healthcare. So what is ACP? Here, if you see, it defines, or ACP reflects as an ongoing process of communication. So it's not a one-off process, it's an ongoing communication among the patients, their families, their loved ones, segregate decision maker. I will talk about segregate decision maker later on in the lecture, and the healthcare providers, where we talk about prognostication of the patient's illness or disease, the therapeutic option, what are the patient's life goals or wishes, values for further treatment, and these are addressed to make sure that we better honor the patient's preference. So ACP allows an individual to plan for their future healthcare in the event they are unable to make their own decision. So ACP should be or may be conducted in any healthy individual, or at any point when a patient is being diagnosed with an illness. It can be cancer or non-cancer, or even a progressive illness such as neurological illnesses such as motor neuron diseases. Okay, so what are the availability of ACP? If we look in ACP advanced care plan in Malaysia, we do not have any national ACP program, and ACP at this point of time is not a legal document yet in Malaysia. However, if you look into in my slide at the moment, in other countries, even in Singapore, which is our neighboring country, they do have a ACP national program, whereby they talk about this AIC living matters. And then even in Taiwan, with the Ministry of Health and Welfare, they do have a framework of ACP for their patients. So we are there in Malaysia. There have been regional initiatives by certain organization, and even in certain hospitals like Selayang Hospital, in Hospital Q, Queen E, Cardiology Unit, and even in Hospice Malaysia. In my center, myself, in University Malaya, we do ACP for all our patients who are seeing us under palliative care. However, this is just documented in the case notes in our EMR system. But like I said, it's not a national program at the point of time. But we hope that in future, in the near future, ACP would become a national program and would be actively done on for all patients in Malaysia in all the other states. So we should advocate for ACP. Okay. So what is the purpose of ACP? It offers patients or people opportunity to plan for their future care, future health care, looking into their medical treatment and what they have to do or their capability to do so. Okay. So why does it matter? It offers and facilitate into what are the optimal selection of optimal medical and non-medical care. So we are not only talking about medical care, it does include non-medical care options too throughout the patient's disease journey, and while they are still able to retain their capacity to make a medical decision making. ACP does not typically result in increased distress for patients or segregate decision maker and is not associated with bereavement complications for segregate decision maker. So we have to understand that by doing ACP, it does not cause somebody or the patient to be extra distressed, anxious, or even stressed. So like I said, it's an ongoing process. I will talk to you about how we should initiate later on. So it should be an ongoing process. It's not a decision, or ACP is not being forced on the patient. It is a open idea to the patient, whereby if they are willing to discuss it, we will proceed on. But we do give them the idea that this is a discussion that we can make and we can record down for future medical use when they cannot make their own decision. So who are involved in ACP? Of course, the patient, his or her segregate decision maker. This can also be family members, even though they have their segregate decision maker, family members or even next of kin can also be involved. And of course, the involved clinician who is caring for the patient. So what are the components of ACP? Before we can do a ACP, what happens is we have to understand, we have to reflect and discuss about the patient's general health state, what are the treatment or care options in his or her context of values and goals. And then we can then start initiating and formulating a plan and document it. So we have to then communicate this plan to involve the loved one and the medical team. So a patient cannot just do a ACP, they write it on to a piece of paper. Okay, what I want if in the event when I'm sick or I'm unable to make a decision, and just keep quiet. They have to communicate this plan to, of course, the medical team and to the next of kin. And it also includes reviewing whatever the plan written at a periodic time. So it has to be reviewed regularly. And but however, his or her values and goals should remain unless this patient change their values and goals during this process or this disease journey. Okay, and then of course we act on the plan under the appropriate circumstances. Before we can do a ACP, the patient and the clinician, including their segregate decision maker, should understand their disease, the person's disease, where is the disease trajectory, understand the expectations of the patients, the values and goals of this patient. I would like to proceed to disease trajectory. So for us as a physician or a clinician, we have to know that there are several factors that influence an individual prognosis. So the diagnosis can be influenced, the outcome can be influenced by the comorbidities, the treatment option, even patients' own emotional stress can also decide on or look into the patient's individual prognosis. So we have to understand the disease trajectory so as to enable us to guide the patient and segregate decision maker into assisting them into making their own ACP, advanced care plan. So we have to understand the disease process. What is the natural history of the disease? What are the acute disease process that can cause exacerbation, and of course, any concurrent diseases, comorbidities, diabetes, hypertension, even heart conditions that may change the disease trajectory or even prognosis, and what are the treatment options. So when we discuss ACP, sometimes what happens, there will be patients when trying to talk to us or even ask us, how long do I have? Are they just inquiring about life expectancy, or what are they trying to ask us would be what the unspoken question is, what will happen? So by being aware of each individual patient's disease trajectory, we are able to answer this question and of course guide the patient into better understanding of their own disease and prognosis. So by doing this, these patients, we are providing a broad time frame, and patients can also be able to look into their own individual needs, understand their situation and control and empower them to make their own decision into their medical condition. So this would be an important implication to healthcare, so that we can give appropriate care for patients with different disease trajectory. So just to highlight or to to be aware, we have three main disease trajectory, which is for cancer, organ failure, and of course the frail, elderly, and dementia trajectory. So we also have to know that physical, social, psychological, and spiritual needs of patients and carer would vary according to their disease trajectory. And we have to be aware that all these needs to be looked into to tackle the patient's different experiences during the disease process and also their individual needs. So what are the clinical implications when we are aware of disease trajectory is that we are able to do everything that is possible for care and not be misdirected. And this can be then conveyed to the patient of what is the available treatment and what are the limitations to maybe we can do for his or her condition. And we also have to acknowledge that patients may progress and death may occur. And with this also, with us discussing about disease trajectory, prognosis, we can prevent unnecessary admission to hospital or even aggressive treatments that may not be beneficial to patients. And of course, we allow all the options of supportive care, just focusing on quality of life and symptom control. And this concept can be inculcated into patients' care early, and of course, may be more beneficial. And one important thing I would like to highlight would be the realistic dialogue that we would have with patients and family members regarding their illness. With this also, what happens is we can optimize providing quality of life. Timely, dignified, and peaceful death can occur with the aims of palliative care. So we know what is necessary and not necessary. Also, with disease trajectory allows our practical planning for a good death. Some patients attempt to gain control on their illness by acquiring this knowledge. So it is very important for us to have this open discussion, frequent discussion, updates of their disease conditions with the patients. So when do we start ACP? ACP should take place in an outpatient setting. Can it take place in an inpatient setting? Yes. However, I would recommend that it should be occurred in an outpatient setting when the patient is more stable, they are not in a condition whereby they are too ill to really discuss and understand what's going on. Because if you are inpatient, most of the time, patients may be too ill or they may be too lethargic to even participate in the advanced care planning discussion. So ideally, outpatient, but if the circumstances allows in our inpatient setting, you can still proceed. Like I said, it should occur in a relatively healthy stability and should be initiated by a physician. So usually I would recommend the main physician that has been taking care of this patient, who has built good rapport with the patient and even the family members, to initiate and do this ACP. Because when you have better rapport with the patient, they do share more about their values and their goals of care more openly. And of course, you would be easier to accomplish. However, if you feel there's no one physician that can do it, you can always do to a patient and always take timely. It can be not just done for one ACP document for in the one setting. It can be done over several settings in the clinics. Okay, so our clinician roles in supporting ACP. So like I said, we have to systematically incorporate ACP into patient care. We introduce the topic to the patient whenever possible or whenever there's opportunity. You clarify the patient's understanding about his or her concern, her goals, her values, so that we are able to support medical decision at any point when patient is unable to voice their own decision making or their own values. We also must make sure that you ascertain the patient's and family's understanding of the disease, the process, prognosis, and what are the available treatment options, and clarify whatever that is inconsistent or maybe there's a discrepancy in the understanding. Always when you start a ACP discussion, do not start by talking about withholding or withdrawing treatments. Because this is not the goal of ACP. So again, I want to highlight here, the goal of ACP is not about talking about withholding or withdrawing treatment. It is how it's more about what we want to provide the care of the patients according to their values and their core values and goals of care when they are unable to decide for their own medical care. Okay, so we also have to ensure like I said, the key stockholders just now, as I mentioned, the segregate decision maker, the next of kin are all on the same page when they understand regarding the patient's medical situation and also their care option, treatment option. And they should be aware of the patient's values, goals, about their preference for and against whatever care options that may be required in future. There should be a transparency about the advanced care planning and the availability of this plan to all settings, in the home, maybe in the nursing home, or even in the hospital. So in what happens is, if we are doing a ACP for a patient, ideally, of course, all these discussions will be documented in the patient's case note. I would also encourage the patients to actually jot down all our discussion and keep it in his bag or in his near his appointment card, so that whenever he comes to the hospital in an emergency or acute setting, this document is available near him or with him during this process, and we are aware of his values and also goals, and also whatever options that he would have already discussed when he was in a state of health stability, so that there is easier for the healthcare providers that are available during this acute setting to provide care. At the same time, even though we have done a ACP, we should always revisit this plan periodically. So maybe you can look at it every yearly or 6 monthly, or according to patient's disease status. If you are looking at a patient who is having MND, more symptoms progression, maybe we have to look into this ACP discussion and revisit what we have discussed and make sure that it's still consistent with his current values and goals for healthcare. Always encourage the patient to bring his segregate decision maker or even his proxy at the appointment so that everyone is aware of the decision that is made during this consultation, and also during any change in the discussion during this care is always updated. So a segregate decision maker. So sometimes patients do ask you, how do I want to decide on who is my proxy or segregate decision maker? You should emphasize that the selection of the person by the patient should be someone who is familiar with the patient's values and goals for healthcare. He should select this person. And once he select this person, of course, we have to ensure and check that this person is willing to accept the responsibility and the role. Sometimes some person even have been appointed by the patient may feel that this is a burden and may not want to take up this role. So it's more of willingness, not being forced into the role. And of course, we should involve this segregate decision maker in the advanced care plan decision. When we have identified the segregate decision maker, we have to ascertain the segregate's ability to make decision based on the patient's wish and not on his or her personal wishes. Okay, so sometimes if a patient picks maybe his son, make sure that whatever his decision is based on the patient's core values and goals and not on his own personal views. Okay, always clarify regarding the flexibility that the patient will grant the segregate decision maker in making the decision for him, and so how much leeway can there be a change to the decision. And we do not want this person to actually divert from whatever we have discussed. So segregate decision maker should actually follow whatever that has been stated in as preference and should not divert from whatever that has been discussed. However, if there's some degree of flexibility and is already agreed upon, is still able to be done. So now I would just want to focus on motor neuron disease. So here, motor neuron disease and the advanced care plan, we have to be aware that motor neuron disease is an incurable progressive illness characterized by decline of neuromuscular function. So timely commence of advanced care planning may enable patients to participate in future care choices. So I would say we have to make sure that we have identified a right time and appropriateness. So it should be identified early because there's progress decline in neuromuscular function. If we are too late, maybe some discussion may not be able to proceed further because of this. So what should be discussed specifically for patients with motor neuron disease? Of course, generally about advanced care plan, of course, we want to know what is the patients, what are the patient's core values, what are important to patients. So what are, for instance, if you are terminally ill, what would you want to continue antibiotics, you are admitted for infection, you're progressing, what would the best care that you want. So these are things, but in motor neuron disease, what we want to discuss further with them would be regarding ventilation, because they would have ventilatory issues later on as the disease, whether intubation and IV would be something that is aligned with their goals and values. What about artificial feeding, as they are progressively becoming the swallowing is declined? What happens if they cannot start having issues with swallowing? Should they discuss about NG feeding or even PEG insertion early? Because this should be started early. And what happens if they do not want any NG or PEG, however, they are unable to swallow any fluids because of maybe they are choking, they have a lot of salivation? Would IV fluids or even oral fluids be something that they look into? Of course, if there's certain complications, what would they want? What are common symptom control? Sometimes some patients would benefit from opioids, but there are patients when they are, even we offer opioids, they do have their own personal views and also goals of not trying to start on opioids because they feel that they would want to suffer with the symptoms to feel. There are some patients with spiritual values that feel that they should just suffer the symptoms or go on with the symptoms. Some do not want to have opioids because of maybe previous experience by other family members or even friends. What are the options about comfort care? And obviously, we also have to talk about end of life care. Where would the place of care would be? What DNR status? So these are common things that we should include in our MND case patients discussion regarding ACP. So here I would just want to towards my end of my lecture, I would just want to highlight a systemic review regarding advanced care planning in motor neuron disease, whereby they look at this. They look into over 400 articles. However, they finally only look into 16 articles, which is more relevant to advanced care planning in motor neuron disease. And they found that all these 16 papers did mention that disease progression was the strongest predictor of ACP completion. ACP clarifies patients' wishes and promote communication. And also, they do highlight that the healthcare providers' attitudes and lack of awareness may limit ACP process. That's why we are having this ACP lecture this morning, to make sure that everyone is aware, you are sensitized regarding ACP, so you are more open to provide this ACP discussion with patient, and also to initiate ACP discussion with your patients. And we also looked at what the paper systemic review looked also, that patients' preference vary according to their disease. And that's why we always have to review this ACP periodically, because the values and preference change over time. They do say that important benefits associated with ACP in the context of MND includes the feeling of control, relief, and also refusal of unwanted treatments. So for instance, like I said just now, we mentioned about treatment of ventilation, treatment of artificial feeding, about symptom control, comfort care. So when we discuss ACP with patients, we give them a sense of control of what they want in their care, for medical care, and also what are their own wishes during this disease or this time. So with that, I would like to just conclude by giving you a few take-home message. So number one, ACP is important. However, many are still not aware or not sensitized to doing a ACP. I would like to also highlight that ACP is not only for patients who are terminally ill. They can be initiated early in the disease or when the patient is just been diagnosed. It is an ongoing process. It's not a one-off process, and it should be reviewed timely. And remember, it should always be initiated by a physician. You should start initiating this conversation so that they are aware that there are this type of conversation and this can take place.